Welcome to this your channel, Clinical Consultant. This time I come to talk about autoimmune hemolytic anemia, a topic of the series of anemias that we will talk about on this channel. I hope that if you like it and subscribe to the channel, that would help me a lot. Let's keep going. Autoimmune hemolytic anemia is an anemia secondary to premature destruction of red cells by the binding of autoantibodies, the complement system, or both. Signs and symptoms. Between its sickness and its symptoms we have paleness and jaundice. Murmur tachycardia. If anemia is severe, the most frequent presentation is dyspnea and fatigue. Patients with intravascular hemolysis may present with dark urine and low back pain. The existence of hepatomegaly associated or not with lymphadenopathy or a base lymphoproliferative process or a malignant tumor, splenomegaly may indicate hypersplenism as the cause of hemolysis. Etiology. If mediated by warm antibodies such as immunoglobulin G, it is often idiopathic or associated with leukemia, lymphoma, thymoma, myeloma, viral infections, or collagen vascular disease. If it is mediated by cold antibodies such as immunoglobulin M and complement, in most cases it is often idiopathic but sometimes associated with infections, lymphoma or cryoglobulin diseases. And then, there are those induced by drugs. It can also be by three fundamental mechanisms. The first of them is the antibodies against the Rh complex such as methdopa. The second is antibodies against the complex of red blood cells and drug-induced by heptins such as penicillin, and the third is for antibodies against the complex formed by the drug and plasma proteins, the complex drug-antibody plasma protein that determines the destruction of red blood cells, which only passed out there innocently as in the case of quinidin. Differential diagnostic. Obviously, autoimmune hemolytic anemia should be differentiated from a hemolytic anemia produced by a defect in the membrane. In this case it can be caused by paroxysmal nocturnal hemoglobinuria or spur cell anemia and can also be caused by Wilson's disease. It must also be differentiated from non-immune anemia. In this case it can be microangiopathic hemolytic anemia, hypersplenism, cardiac vascular prosthesis, giant cavernous hemangiomas, hemoglobinuria due to gait, physical agent, infections, heavy metals and certain drugs such as nitrofurantoin and sulfonamides. Medical evaluation. The assessment consists mainly of laboratory confirmation of hemolysis and ruling out other possible causes of anemia. Although most cases of autoimmune hemolytic anemia are idiopathic, possible causes should always be searched for. Lab tests. Initial laboratory tests can be a complete blood count that indicates anemia, a reticulocyte count that will be elevated, the liver function tests, in this case the indirect bilirubin to be elevated and also the LDH. In the blood smear we can see the Coombs test. What is the Coombs test? The direct positive test indicates the presence of antibodies or complement on the surface of the red blood cells, while the positivity of the indirect Coombs test shows the presence of antibodies against red blood cells circulating freely in the patient's serum. We can also find the haptoglobin concentration, which in this case we find decreased. We found the presence of antibodies, in this case immunoglobulin G and immunoglobulin M. Hepatitis and anaserology. Also urine test can demonstrate hemosidenuria and hemoglobinuria. Diagnosis by images. A chest X-ray may also be indicated, and an abdominal or chest cord scan may also be considered to rule out lymphoma. Non-pharmacological treatment. Stop any drug that is causing the anemia. Exchange transfusion or plasmapheresis only in life-threatening cases. And avoiding exposure to cold in patients with cold antibodies. Acute treatment. Prednisone 1 to 2 mg per kilogram per day in divided doses initially in autoimmune hemolytic anemia due to warm antibodies. Corticosteroids are ineffective in this disease because of cold antibodies. Splenectomy in patients who do not respond adequately to corticosteroids when red cell sequestration studies indicate splenic sequestration. Immunosuppressive drugs associated, or not with immunoglobulin only when corticosteroids such as splenectomy fail, unless there is a contraindication for surgery. Danazol often combined with corticosteroids may be useful in autoimmune hemolytic anemia due to warm antibodies. Immunosuppressive drugs such as athioprine, cyclophosphamide may be useful in autoimmune hemolytic anemia due to warm antibodies but has only been indicated when corticosteroids and splenectomy, unless there is a contradiction to surgery, have failed to achieve adequate remission. Forecast. The prognosis in general is good. Unless anemia those, or it is an underlying disorder with a poor prognosis such as leukemia or myeloma. Derivation. Consult with hematology all cases of autoimmune hemolytic anemia and consult with surgery in refractory cases to evaluate a splenectomy. Thank you very much for watching the video. The next video will be pernicious anemia. Thank you very much for watching the video. Subscribe, like, comment. Until next time.